Well, good morning, everyone. My name is Bernie Jaroslaw. I'll be facilitating this webinar, and I am the marketing manager for Whitmix. The webinar this morning is Practical Screening for Sleep-Disordered Breathing in Clinical Practice, a very interesting and timely subject. This morning I have the privilege of introducing Dr. Stephen Bender, and because I'm at home with I think a broken foot, I'm going to have Dr. Bender tell you a little bit about him. I don't have his bio in front of me, but he will be introducing himself in a moment. Just a couple housekeeping things. Number one, this webinar is indeed being recorded, and that recording will be available to you within approximately 24 hours on the Whitmix website. Just go to whitmix.com and look in the webinar section. It's on the home page. Secondly, this webinar will give you 1 hour credit, CE credit, and that again takes about 24 hours or so before it's processed. And you will be contacted, and actually you'll be contacted with a very short and easy test to prove you were here and listening, and we'll send you the CE credits right after. And thirdly, there's a question box you can see, and you are all available to ask any questions, but I ask that you hold them for the end of the webinar and then type them in. We can't hear you, but we'll be able to see I'll be able to see your questions, and we'll verbally pass those on to Dr. Bender. So without further ado, Dr. Stephen Bender.
Well, thank you, Bernie, and good morning, everybody. Thanks for taking the time out of your day or evening or whenever you're tuning in. For this webinar, and really, as Bernie said, this is a really important topic. You probably all are aware of the major push going on in dentistry to screen our patients for sleep disorder breathing and then provide therapy. So hopefully we can give you a little bit of a start on that to, next day start screening these patients, and then hopefully you'll choose to educate yourself more in this field, because it's probably one of the most rewarding things I've done in my career. So with that, just a short bit about me. I graduated from Baylor College of Dentistry in 1986. I was a restorative general dentist for approximately 12 or so years, and gained an interest in facial pain, temporomandibular disorders. So I decided to go back to school, and I studied orofacial pain at the University of Florida for a couple of years. And after that point, I decided that that's what I wanted to do with the rest of my career. And so since that time, since about 2000, I've limited my practice to orofacial pain, and then more recently, we've incorporated more and more sleep medicine into our practice. About 3 years ago, I decided to leave private practice and join the faculty at what is now Texas A&M College of Dentistry, in part to try to help educate our young students in the field of pain, but also try to incorporate more sleep medicine into the curriculum. And so that's been a really rewarding experience. So with all that said, well, a little bit again, just getting into sleep. When we trained in orofacial pain many years ago, we did learn about sleep, but the main thing that we learned about was how to help our patients sleep better to help manage their pain. And so a lot of what we did was pharmacotherapy, and then if people had sleep disorder breathing, I personally would refer them to other dentists to make oral appliances and other types of treatment modalities. But over the years, through encouragement of some very good people, I've incorporated more and more into my practice. And so, yes, I'm an orofacial pain specialist, but a lot of what we do is help our patients sleep. So I would like to share with you just how we go about screening our patients that may have sleep disorder breathing. So my slide is not advancing. There we go. So you know, we could say, what's the big deal? Well, we know that a third of our life is spent asleep, or should be spent asleep. We also know that, hang on just a second, I'm sorry. I can't see all my slide. Okay, I'm back. Now, we also know that most, like 95% of sleep disorders are not diagnosed, they're not identified. And of those, 82 to 98% of sleep-related breathing disorders are undiagnosed. So we have a significant amount of our population that have sleep disorders that are unrecognized, and a lot of those have sleep-related breathing disorders. Another problem is that in medical education, they spend about 2.5 hours on average learning about sleep in a 4-year curriculum. Probably 17 minutes of those is spent on pediatric topics. And interestingly and astoundingly, almost a third of medical schools have no education in sleep medicine. And so unless a physician learns sleep in their residency program, or they attend a sleep fellowship, in most cases, they have very little training in sleep medicine. So the opportunity for the dentist and the dental teams is partly due to the fact that we have developed over the years a very efficient and effective well care model. In other words, we have encouraged our patients to maintain their oral health to come see us either twice a year or at least yearly, whereas in medicine, let's face it, most people don't go see their physician unless they're sick. We have the perfect model to help screen our patients, and we can also, there are therapies that are unique to dental providers for us to do, so we can work very effectively with our physician colleagues to provide effective treatment options for sleep disorder breathing. My opinion, and you can take it for what it's worth, but due to the significant amount of health risks associated with sleep disorder breathing, or sleep disorders in general, I believe that every dentist, every dental team should commit to becoming at least screeners of our patients for sleep disorders. Now, that could mean that you decide you only want to screen and then refer for treatment, or you can get very involved and become part of the treatment team. But I think it's so important, the more and more we recognize about sleep disorders, that we at least become involved at some level. So what is sleep disorder breathing, since that's what we're going to be focusing on? It's basically a group of disorders characterized by respiratory pattern, or pauses in our breathing, or the quantity of ventilation we get during the sleep period. Bottom line is, sleep disordered breathing is less or no air during periods of our sleep. So we'll look at a couple definitions before we get into the actual screening part. Hypopnea, that's a term that literally means a shallow breath. It is considered a partial airway collapse. It can be with or without noise or snoring, but by definition, it's at least a 30% reduction in airflow lasting at least 10 seconds. And it's usually accompanied by a greater than or equal to 3% drop in our O2 saturations, or it can include an arousal. And then apnea literally means without breath. So this is going to be a period of time where we actually stop breathing for at least 10 seconds or longer during the sleep period. Apneas can be termed obstructive, which means we have tissue obstructing the airway, or they can be considered central. And this is basically where the brain, for numerous reasons, decides not to breathe. In other words, it just kind of shuts off and says, no, I got this. And there can be a lot of health issues associated with that, but it can also be related to medications like opioids. Now, respiratory effort related arousal is going to be an event that is characterized by an increasing respiratory effort that lasts at least 10 seconds or longer, that will lead to an arousal from sleep. This will not fulfill the criteria for hypopnea or an apnea, but it does interfere with sleep as if it were an apnea or hypopnea. Now, I keep saying arousal. What does that mean? Arousal is a period of time where our brain wave activity or brain activity goes from a very slow, stable state into more of an awake-looking state. Even if we don't awaken fully, the brain starts to activate. We see increase in stress, stress factors, and other mediators in our brain that would signal that it's waking up. Now, another definition would be the apnea-hypopnea index, which is going to be a measure of severity of sleep disorder breathing. So that's going to be taking the average number of apneas, or where we stop breathing, with the number of hypopneas and averaging that per hour of sleep. So when we take that all together and we average it per hour of sleep, less than 5 of those is considered normal. 5 to 15 would be considered mild sleep apnea, moderate would be 16 to 30, and then above 30 would be considered severe sleep apnea. Another measure is termed the respiratory disturbance index, or RDI. That would include not only the apneas and hypopneas, but the respiratory effort related arousals. So this is going to be any obstruction or partial obstructive event leading to an arousal. This measure has mostly replaced the apnea-hypopnea index as far as a measure of severity of obstructive sleep apnea. So you can tell by the definition and by the parameters that this number is usually a little higher because we are including another parameter into the equation. Okay, so with that, let's figure out, how do we identify these patients in our practice? We all know that we have them. But how do we pick them out? Well, the first step is just talking to our patients. We can just ask in a very informal way, do you snore? Is it frequent? Is it loud? Does it wake your bed partner? Does it wake your roommate or housemates? Has anybody seen you gasp or choke as you're awakening from sleep? Or do you yourself awaken kind of choking or gasping and thinking maybe it's allergies or drainage? Hypertension has been now correlated very strongly with sleep disorder breathing, almost to a cause and effect relationship. So I advise doctors, any patient that's taken an antihypertensive, or you measure hypertension consecutively in their visits, you should start screening them for sleep disorder breathing. Insomnia as well. If a patient is taking medications for insomnia or reports insomnia, there's a lot of data that would suggest that a lot of insomnia is misdiagnosed obstructive or some type of sleep disorder breathing. What happens is the patient will attempt to go to sleep, and they're usually awoken relatively quickly due to obstruction or partial obstruction, and so their brain kind of plays tricks on them, indicating, hey, I'm awake. I'm watching the clock, I'm awake, I'm not sleeping. When in reality, they're actually going in and out of light sleep. So a significant portion of patients diagnosed with insomnia actually have sleep disorder breathing, especially your postmenopausal females. Patients that wake up with morning headaches, especially the headaches that they say they wake up with, they don't take medication, within an hour or so they go away. Do they have daytime sleepiness? Do they have to sleep with water by their bed? Do they awaken constantly with a dry mouth? Depression and anxiety can also be a significant comorbidity. Memory problems, night sweats, those that have excessive movements in bed, those that have to get up frequently to urinate during sleep, or that they bedwet. So the next step would then be the actual screening. We can do that in a number of different ways. We can use validated questionnaires. We can do an appropriate physical exam, and we'll talk about these measures, and then home screening. And we'll talk about one way that I prefer and that I tend to recommend for home screening. So there are a number of questionnaires that can be given to patients, and these are super easy to just pull off the internet, put it into your screening form. It doesn't take much effort at all to incorporate these into your practice. Two that are relatively common, that are commonly used, would be what's known as the Stop-Bang questionnaire, and then also the Epworth Sleepiness Scale, which is a measure of excessive daytime sleepiness. So the stop bang, as you maybe have guessed, is basically an acronym. It stands for, do you snore? Is it loud? Are you tired during the day? Has anybody observed you choking or gasping? Do you have hypertension or high blood pressure for the P? Is your body mass index more than 10% over the ideal? Are you over the age of 50? What is your neck size for men? If it's greater than 17 inches, in a female, greater than 16 inches is indicative of the potential for sleep disorder breathing. And it says on this form, ask the men their shirt size. We've all seen the guys that come in, you say, what is your shirt size? And I say, well, I'm a 16.5. And you look and you see, you can tell those top two buttons, they are never going to meet, not in this lifetime. So you should actually measure the neck size of your patients. And that's a real easy thing to do. It's a real neat thing to incorporate into your hygiene visits. And then gender, are you male? That's going to add to the equation. So 0 to 2 positive answers would be a low risk. If they have 5 to 8 positive answers to these questions, they will have a high risk for sleep disorder breathing. And this, again, is a validated questionnaire. Now, the Epworth Sleepiness Scale is another validated questionnaire, more so for, as I said, excessive daytime sleepiness, but it can give us an idea, not just for sleep disorder breathing, but are our patients having difficulty with their sleep? And so it's a series of 8 questions with a potential score of either 0 to 3. And it's how likely are you to doze off during these certain circumstances? So it would be like sitting and reading, watching television, sitting in a public place like a movie theater where you're not active, as a passenger in a car, if you lie down to rest in the afternoon, if you're sitting and talking to someone, if you're listening to a Bender lecture, that was a joke, sitting quietly after lunch without alcohol, in a car stopped at a red light. So 0 would be no chance and 3 would be a high chance. And so there's a potential to score a 24 on this particular test. With this test, less than 10 positive or less than a 10 score would be considered normal. Greater than 18 would be very sleepy. Now, the thing about this test is it was first validated back in 1991 on hospital personnel. And so hospital personnel tend to be more adept at shift work. And so their perception of being tired may not be what the average person is. And so this test is being looked at more recently, looking at are these numbers really valid for the general population? So there's some writers that would indicate possibly an 8 score would be, a less than 8 would be normal. So kind of keep your eyes tuned on the literature for that particular test. Now, also, besides our questionnaires, we need to do an appropriate physical exam. And the basics of this are really, again, not going to add too much into your normal process. We take a neck circumference, as we talked about. You need to record the weight to get your body mass index. And then there's some certain facial, nasal, and oral features that we'll be looking at. And then, again, we'll look at home screening in just a minute. So we talked about the neck circumference, greater than 17 or greater in a male, greater than 16 in a female. There's also been an adjusted neck circumference that was validated by Fleming's back in 1994 that looked at what parameters can we add to this to make it more precise. And so with the adjusted neck circumference, you take the neck circumference in centimeters. If the patient has hypertension, you add 4 to that score. If they snore, you add 3. If they choke and gasp, you add 3 more. And so a score of less than 43 would indicate a low probability, and above 48 would indicate a high probability of sleep disorder breathing, or in this case, obstructive sleep apnea. Now, we all are probably familiar with body mass index, and it's real easy to get body mass index these days. You can get charts and graphs that you can actually put into your your treatment area that you can laminate and talk to your patients, I use the Hippocrates app that I can easily calculate the body mass index. One of the reasons we need to document this is as the patient goes forward, this needs to be part of their record for insurance reimbursement. In other words, why are we doing this treatment? But we also know that the prevalence of obstructive sleep apnea in obese patients is going to be approximately double that of normal weight adults. It's even greater in persons with upper body obesity and a BMI over 40. And we know that obstructive sleep apnea is directly related to obesity in over half of the subjects. So what about nasal, oral, and facial features? I mean, some people you can look at and you can just tell, you know, this person, besides being obese, just does not look well. I mean, you can tell by the eyes, you can tell by the facial affect. So in some cases, it's very obvious just looking at patients that they may have a disorder. And when we talk about the eyes, you look for the dark circles or the shiners, the allergic shiners under their eyes. This is venous pooling under the eyes that is thought to be somehow related to excessive sympathetic activity. So if we're not sleeping good, we're going to have more sympathetic activity during a period of time, sleep, where it should be more parasympathetic. And it's thought that we are more apt to have venous pooling if we have an overabundance of sympathetic activity. You can also see it in children. Again, the allergic shiners may not be allergies. It may be related to sleep disorder breathing. So this is one of those things, the more you see of these types of patients, the more it will instantly clue you in that you need to check these patients, especially with the kiddos. When you look at children, you can just start picking out these different aspects of their features. Some people, it may not be as obvious. In other words, we may see the very thin, narrow faces. We may see people that look very healthy and fit that just don't fit the profile. When you look in their mouths, you'll see very narrow vaulted arches of the palate. And so why is that? Why would these patients be as susceptible? Well, I'm not a physicist, so bear with me, but there's a couple laws of physics that would suggest why the airway is more collapsible in these people. In other words, if we have a smaller tube for a substance to go through, it's kind of like squeezing the water hose. The more you squeeze the water hose, the faster the water goes through it. Well, the smaller the space for air to go in, and that would be the nose, the upper airway, the faster the air is going to go through that tube. And then the other principle would indicate the faster that substance goes through that space, the more negative pressure is created. So the faster the air is going through this collapsible tube, the more negative pressure is created, leading to enhanced collapsibility. This one is kind of, I like to think of it as like you step into a shower that has a shower curtain on, you turn the shower on, and that curtain starts drawing in. So that's the same principle. So with these smaller airways, and this is another example, you can see the small airway, this small lower jaw, and also notice that this patient is mouth breathing. So with this smaller airway, the person is less prone to breathe through their nose because they probably have a narrow nose that we'll talk about in just a minute, and they establish oral breathing throughout their life. And you can imagine if you're orally breathing as opposed to nasal breathing, you're not going to then develop the nasopharynx as well. If you're orally breathing, the tongue is going to lie on the floor of the mouth as opposed to positioning on the palate, which enhances the development of those structures. We also know that when we breathe nasally, there are receptors in the nose that actually help facilitate muscle tone in the oropharyngeal area. So we have an increased risk of upper airway resistance or collapsibility if we are breathing orally as opposed to nasally. And if you look at most healthy sleepers, they do tend to breathe nasally while they sleep, not orally. So getting to the nose, we want to inspect the nose too as part of our preliminary exam. In other words, we're looking at the face, we're looking at the eyes. We also want to notice the nose because we want to see what kind of passageway we have for that area to go through. So as much as you may be resistant to do this, if you're going to get into sleep medicine as part of your dental practice, you need to get comfortable looking in noses. Patients love it, we love it, it's a great time. But we need to assess how well air can go through the nose. So when you're looking in the nose, you will first notice if there's any septal deviations, but also the turbinates. And when you inspect the nose, you will only be able to see the inferior and middle turbinates. So you want to look and see if they're enlarged. And I know in our area in North Texas, there's a lot of allergens, and so most people will have inflamed turbinates. So if that's restricting your airflow, again, it's going to cause more collapsibility downstream. Also, just a side note, if you are using a speculum to look in the nose, you want to do it as it's pictured. If you turn it the other way and you press those sides of the speculum, the nasal speculum, against the septum, that tissue is very, very exquisitely tender. And so you might get a quick withdrawal of their head. So using these nasal speculums, do it just as it's pictured here. Also, when we're looking in the nose, we're looking at what are known as the nasal valves. There are two basic nasal valves. There's the external nasal valve, which is basically the nares of the nose, and then the internal nasal valve, which is where the upper lateral cartilage intersects with the septum. This area needs to be about 10 to 15 degrees in width. Now, do I take a protractor out and measure these? No, you just kind of get a feel over time for what about 10 to 15 degrees is. And again, if this is structurally smaller, that's going to create more turbulent airflow as the air goes in. We also look for external nasal valve collapse. So when a patient, you may just have a patient breathe in really hard, and when they do, if their nares collapses, that is something they can maintain while they are awake, but when they go to sleep, those will collapse and restrict airflow, which could lead to more oral breathing. A good test if you suspect this is just to, if you suspect either internal valve restriction or external valve collapse, is what's known as the Cottle test or the Cottle maneuver. This is basically where you just have the patient or you kind of tug on these areas pictured in this image and ask them if they feel like they can breathe better. So you just a light tug on the aspects of the face, kind of in the malar ridge or the zygoma area. You just pull out a little bit and just say, do you feel like you can breathe better? Now, what if we do have impingement in this area? What if they do feel like they can breathe better? Then a consult with an otolaryngologist might be in order. In other words, this person may benefit significantly from different procedures in the nose that could facilitate nasal breathing. Then we also look in the airway. Obviously, we're dentists, we're going to look in the mouth, but as opposed to just focusing on the teeth, we need to look at the structures in the air that make up the airway. So when we look at the mouth, this would be considered a normal airway. You can see space back there in the what's known as the oropharynx, which is the area of the airway just past the boundaries of the mouth. When we look at the tongue, we would consider this macroglossia. If the tongue lies above the level of the occlusal plane, that's considered macroglossia. It's a significant finding that's somewhat predictive of sleep disorder breathing. It can also be indicated. It can also be present in people with thyroid disorders too. So it's not something to just totally ignore. But with these people with macroglossia, we will often see ridging of the lateral borders, even of the anterior borders. Sometimes this is called scalloping. Sometimes it's called crenations of the tongue borders. And in this particular study, almost 400 men and 700 women ages 30 to 79 years, they found that scalloped tongue was associated with higher prevalence of moderate to severe obstructive sleep apnea, and it tended to be more prevalent in patients that were overweight. We also want to look for elongation of the uvula and narrowing of the lateral aspects of the posterior pharynx back there. So what dimensions can be considered an enlarged uvula? If it's greater than 1 centimeter in width and then 1.5 centimeters in length, that's considered an enlarged uvula. What causes that? Well, it's probably related to that more negative pressure. In other words, if it's taken more effort to get air in, it's thought that it elongates this tissue back there. And then obviously we're looking for crowding of that posterior oropharyngeal space. So if a person has enlarged tonsils, that's going to restrict airflow as well. And it's not just in kids, we see it in adults as well. Interestingly, certain tonsillectomy procedures will allow the tonsils to grow back. If they have a complete removal of their tonsils, usually they do not, but if they do a partial, in other words, they just put probes inside the tonsils and remove tissue that way, which is less traumatic, but they have a higher predilection for growing back. Now there's ways to assess this space as well. There's what's called the modified Mallampati score. Sometimes it's called the Friedman modified Mallampati. More recently, it's been termed the Friedman tongue position. So what that is, in the Mallampati score, that's a measure of how difficult it will be to intubate somebody under anesthesia. So they will look back in the throat, they will have the patient open and stick their tongue out. For this modified technique, you just have the patient open and you look back there to assess the vertical dimension of the airway. And so it's been found to correlate very significantly with obstructive sleep apnea, according to the measure, the apnea-hypopnea index. So the higher the score, in other words, it's a 0, 1, 2, 3, 4 usually, the higher the AHI has been found to correlate it. And then we also have a more horizontal look at the airway, sometimes called the tonsillar grading scale or the pharyngeal grading scale. So this way we're looking at the lateral dimensions of the airway. And it's not always just tonsils. Again, it can be hypertrophy of those tissues back there. So we're basically assessing, okay, how much room do we have back there in the throat for air to pass through? Now, as far as screening, there are a number of different ways you can home screen, different tests that you can have patients do, home sleep tests, and anywhere from very simple to complex. Pulse oximetry, in my opinion, is a very reliable measure of sleep breathing. It's relatively inexpensive. There's little to no disposable cost. In other words, we don't have to keep buying materials for pulse oximetry. And in my view, what my job is to screen. I'm not looking to make a diagnosis. So the more sophisticated home sleep tests, yes, you can make a diagnosis on some of those. But as a dentist, at least in most states, we are not allowed to make that diagnosis. And again, I prefer working with our physician colleagues. And so I want to screen, I want an accurate screener and a low-cost screening tool. So in my practice, I use pulse oximetry. We have a number of units available to send out. I never charge for it. We just ask to get a credit card number from the patient. And over the many years that we've been doing this, we've only had 2 or 3 that didn't come back. One was stolen out of a car. One was left on top of the car as the mother was loading her children in after the appointment, and it disappeared. So patients are pretty reliable of getting these things back. Now that we're at a downtown location at a dental school, we actually give them a self-addressed envelope so they could just mail it back to us. So we find this to be very cost effective in getting patients screened and then ultimately diagnosed. So what does pulse oximetry do? Well, it's going to have 2 measures. It will record the amount of oxygen in our blood as well as our pulse. We then take this information recorded on these units and either upload it into some web-based programs, or we can get software that we can upload this information ourselves. So the very basics of pulse oximetry is that it's going to be a red or infrared light transmitted through either a finger, a toe, earlobe, which is going to then be presented on a sensor. That signal processor or sensor then will determine the percentage of hemoglobin saturated with oxygen. Bottom line, how much oxygen is in our blood. It is inexpensive. It is very easy to use. It doesn't take a lot of instructions for our patients, and it's very accessible. Again, they're not super expensive relative to other home screening devices. The disadvantage would be that there's only two parameters, the oxygen saturation and the pulse. It is user operated, so the user can mess it up. In other words, they can put the sensor on wrong or other things like that. They are variable in their quality. You can get them very inexpensively, but in my experience, they haven't lasted very long, or the quality hasn't been that great. One other that I didn't mention, one other disadvantage is that with home testing like this, with pulse oximetry, it will start reading as soon as it's put on. So you may think, well, so what? Well, in a in-lab sleep study, the measurements are taken only when the patient is asleep, and that is determined by brainwave activity. So they have a really good way of assessing that. Our tests are going to record even if they're awake. So it's very important when you give these to patients to tell them, put it on right before you go to sleep. Don't put it on, watch TV, read a book, or whatever, because we want to get the most accurate recording. But it will record while the patient's awake, which is hopefully going to look very normal. So with pulse oximetry, there's basically two important parameters to look at. One is called T90, or time below 90% oxygen saturation. If that is greater than 1% of the time that it's worn, or 1% of the night, it is suggestive of obstructive sleep apnea. On the converse of that, if we're using it as a measure of the effectiveness of our treatment, if we can get that number below 1% of the night, then we have most probably successfully treated that patient. And then the oxygen desaturation index, or ODI, sometimes just DI, is going to be, depending on your unit, depending on your software, a 3 to 4% decrease in your oxygen concentration lasting at least 10 seconds. And then that's average per hour. And if you remember, that's very similar to the apnea hypopnea index, where we have this decrease in airflow along with a drop in oxygen saturation that lasts at least 10 seconds. So what are normal parameters? Well, normal oxygen saturation should be 95 to 99%. So a good thing to do, knowing that, is when you hand it out to a patient, as we do, we will put it on and we will make sure that they are measuring normally, 95 to 99%. Below 92% usually indicates some hypoxemia, or something is not functioning properly. A normal pulse rate is going to be, as you are aware, 60 to 100 beats per minute. Above 100 beats per minute is considered tachycardic, or too fast, and then bradycardic is below 60 beats per minute. During sleep, that's a little bit different. If a person has normal blood pressure, the average pulse is about 58 beats per minute, whereas if they have hypertension, it can average around 67 beats per minute. Now, another potential problem with pulse oximetry is low peripheral perfusion. So this could be Raynaud's or other disorders where they have reduced peripheral blood flow. Also, if the patient has a lot of movement during sleep, they're shivering, they're tremoring, they're flexing their finger, they're putting their hands under their pillow, all these different things can affect the variables that you'll get in your pulse oximetry readings. Other problems, external problems, if a person is wearing dark nail polish or acrylic nails, that could interfere with the signal. If they have excessive dirt or grease or grime on their nails, if there's excessive ambient light in the sleep area, if there's moisture on the finger, that will affect the sensors if they don't apply it correctly. So again, it's very important to put it on, make sure they understand how to put it on, before they leave the office. If you're using a sensor that is not appropriately sized, if it's too loose, too tight, that will affect it. If a person has recently had cardiovascular disease, that could affect your reading, and darker skin tones can affect the reading as well. Now, when you do this, what is the patient's response? In other words, how do they feel about this type of testing? Well, there was a recent study at the University of North Carolina. They had approximately 1,800 adult patients. They screened out anybody with a previous diagnosis of obstructive sleep apnea. They excluded pregnancy or less than 18 years of age. Ended up with 124 patients that consented to participate. The data they would collect on these patients was sex, age, weight, height, and neck circumference, all the things that you would include in the stop bang questionnaire. And then also other relevant information like the Epworth Sleepiness Scale. Then they distributed pulse oximetry, and 18.5% of the patients screened as high risk on the stop questionnaire, and this is without the bang, so this is just the stop questionnaire. So 18.5 screened positive on that alone, 26.1 screened positive on pulse oximetry alone, and then almost 32 screened positive on both tests. Of those, the people that scored high risk on pulse oximetry, they were 2.5 times more likely to seek a physician evaluation compared to those who screened on either one by themselves. I'm sorry, on both, on the stop questionnaire alone. I worded that wrong. So the bottom line is patients that scored high risk on pulse oximetry were twice as likely to seek a physician evaluation than those that screened positive on just the stop questionnaire alone. And in fact, the screening on that really didn't significantly increase their likelihood of getting an evaluation. So the bottom line, the takeaway is that if we use the questionnaire as part of our workup, or use the pulse oximetry as part of our workup, our patients are going to be more likely to get a physician consultation. And ultimately, that's what we want. We want them to get to a physician. We want them to get a diagnosis so we can effectively help manage them. So this is a reading, partial printout of a reading of pulse oximetry. So this is in the particular program I use, which is called Profox. This is the top part of the page. And so the important numbers, again, are time below 90. So this particular person, time below 90 was 43.3%, which again is more than the 1% that we want. If we look at the desaturation index, they had 32.5 events per hour. And if we remember back to the definitions of severity on AHI and RDI, above 30 events per hour is considered severe sleep apnea. So with this information, I can comfortably tell my patient or consult with them and say, according to this screening test, there is a significant or high probability that you could have obstructive sleep apnea. So I'm not making a diagnosis, I'm just saying there's a high probability, and I'm then encouraging them to go to a physician to get this tested so it can be appropriately diagnosed. This is another, and I'm a very visual person, so this is a very graphic representation of what the time is. So on the left-hand side of the screen, that's the first part of the night. The first column is going to be the pulse. The second column is the oxygen saturation. So without even looking at the bottom at the scale, you can see a lot of up and down stuff. So if you look at the saturation, or the second column, you can see at the bottom it's marked starting at 70 to 100. So remember our oxygen concentration, we want that to be above 95. If it's dropping down below, you cannot put on one of these pulse oximeters, hold your breath long enough to make it do that. So that is a significant finding. And then when we look at the heart rate, We like to see a more solid, thin line. If it's getting fatter, almost like what I call a caterpillar-looking line, that indicates a lot of up and down. So that's a tachycardic, bradycardic type activity, or increased heart rate variability. What's causing that? Well, again, if we're not breathing good, we're going to have this sympathetic or fight or flight response. The brain's going to say, you got to wake up, we got to breathe. And so we'll see a corresponding response in heart rate variability. And we'll talk more about that in just a minute. So this is another report of a patient, and you can see on the top up in the left, the time below 90 for this patient was 21.3%. And then at the bottom, the ODI, or desaturation event index, 39.5. So you would suspect this person probably has obstructive sleep apnea. And you can again see as the line gets thicker, or the more ink we have on the page, that's problematic. What's also interesting about this is you can appreciate the more time the person is asleep. In other words, we've got the first two columns, which is the first part of the night. Second two columns towards the right of the page is more towards the morning hours. We start seeing more of this activity. And you might think, well, so what? Well, during the first part of the night, we have more deep sleep. During the second part of the sleep period, towards the morning, we have more rapid eye movement sleep. And without going into a lot of detail, we know that the airway is the most collapsible during rapid eye movement sleep because we have the least amount of muscle tone. So towards the morning hours, a lot of these patients will start showing more events. This is why people with severe sleep apnea and compromised health like cardiovascular disease tend to die in the early morning hours. Their system is compromised, and they are more prone to have airway collapse or problems during the later part of the sleep period. So now we'll look at a couple patients. These are actual patients of mine. And again, I have a pain practice. So most patients come in with pain, and then we ultimately screen their sleep to see if that's a factor. So this is a 43-year-old female, BMI 21.94, which is very good, very healthy. Epworth Sleepiness Scale 1 out of 24. So this would be considered normal. Her complaint was tooth pain. Now, when I see a patient with tooth pain, they don't have a tooth problem. It's usually something else. Her other symptoms were headaches, dizziness, night sweats, insomnia. In fact, she was taking Ambien for her insomnia, and frequent snoring. So this is a patient I'm going to screen with questionnaires and also pulse oximetry. So we look at the first page of the pulse ox and we say, well, that looks pretty normal. I mean, our time below 90 is 0. And then the ODI, or desaturation index, is 2.3, which is less than 5. So we could almost say, nothing here. But when we look at the graphic page, again, the first column on the left, that's going to be heart rate activity. That line is getting super, super fat. So that's a lot of up and down activity of our heart rate, suggesting increase in sympathetic activity. So that's problematic. So this person would be somebody that may have what we call upper airway resistance syndrome. In other words, they don't stop breathing, but the airway is getting smaller, making it more difficult to breathe, causing this sympathetic response. So again, in my world, this could be contributing to her pain problem if she's not sleeping well. So again, I mentioned the heart rate variability. If we look at its correlation in pulse oximetry, there's a couple of studies I want to show you. One is a retrospective analysis. In other words, looking back at patients who underwent pulse oximetry and PSG, which is a in-lab sleep study, or polysomnography, in 1 year. So they had both. And what they found was a correlation of this heart rate variability, in other words, this up and down, found in pulse oximetry, who had what we call normal overnight pulse oximetry. That's what was being looked at, kind of like the patient I just showed you. And what they found in this study was that patients with this heart rate variability occurring even with normal oxygen desaturations, in other words, not significant, they had a 5-time increased risk of a diagnosis of obstructive sleep apnea when they then had a polysomnography or in-lab sleep study. and then looking at how this relates to arousals, in other words, the brain waking up from sleep. This again was a retrospective study of patients referred for obstructive sleep apnea who had a previous in-lab sleep study following a home test. So they had a home test, then they had a polysomnography or in-lab sleep study. The hypopneas, or the partial decrease in airflow, along with an increase in heart rate of greater than or equal to 6 beats per minute, was used as a marker for arousal. In other words, they looked to see when the heart rate increased greater than or more than 6 beats per minute. And what they found, that the diagnostic accuracy of their home test was improved if they did look at that marker for arousal. So it's important, the bottom take home is we don't want to just look at the oxygen saturation. We also want to take note of the heart rate variability as a marker for arousal, because that is suggestive of something going on during sleep. So again, back to another patient. This was a 27-year-old male, very fit, very healthy, kind of one of those extreme athlete type guys, BMI 21.7. His chief complaint was that his jaw popped, and he had what he called TMJ. Epworth 0/24. And a lot of your patients will be like this. They'll say, I have all the energy in the world. I can't have a sleep problem. So we can't take just one parameter to make our assessment. No report of snoring, no report of witnessed apneas, but other symptoms were tinnitus, occasional left-sided eye pain, left jaw joint pain, right and left-sided jaw noises, left-sided jaw locking, and he noticed bite changes over time. So we do a pulse oximetry, and again, you see time below 90, 0, ODI 0.5. So it would be really easy to just say, nope, that's normal. That sleep is not your problem. Until we look at the pulse, the heart rate variability. This is probably one of the more extreme examples that I have. You can see on the second column from the left of your screen, the heart rate, the desaturation is his O2 sats are staying almost perfect, but that heart is going crazy for some reason. Now, if somebody has an arrhythmia, a known arrhythmia, this could be a factor. But in this individual, he had no history of cardiac disease or arrhythmias or palpitations or anything. And so I looked at this and I said, we need to get you a sleep study. This is not good. And this is where we talk about not just their pain presentation, not just their sleep, but their overall health. I mean, you can only imagine what the heart is going through to have to deal with this during the sleep period. And then one more patient, a 28-year-old grad student of ours, very athletic, low BMI. Her symptoms, extreme fatigue. She has really difficult time staying awake during the day and focusing. She's very anxious. She has postural hypotension. In other words, she stands up, she gets dizzy, and difficulty with concentration, as I said. So we did a pulse ox, time below 90, 0, and then she had no saturation events at all, desaturation events at all, so it didn't even score. But when we look at her heart rate, again, you can see a lot of up and down activity, a lot of sympathetic activity happening during this sleep period. So she was very excited. We just actually very recently took records to make her a mandibular advancement device. She's very excited to try this. She said she is struggling. She is so tired of being tired and unable to focus. So kind of wrapping that up into a nice bow, you can see the importance. There's a lot of people with sleep disorders out there that are undiagnosed. There's a lot of people with sleep breathing disorders that are undiagnosed, unrecognized. We as dentists and dental teams are in a great position to screen our patients. You can decide, that's all I want to do. I want to screen, or we can get actively involved into the process. So I would encourage you to use these tools like these questionnaires that we talked about. I would encourage you to incorporate into your exam different parameters that actually don't take up too much more of your time. And then I personally like pulse oximetry. It's easy, it's relatively inexpensive. We've got like 9 or 10 units that are out all the time. The most gratified patients are going to be these patients that you help with sleep breathing. you do, wonderful restorative work and your patients are appreciative, or they're not, they don't like the shade. When I transitioned into pain management, patients are extremely grateful if you can manage their pain, but if you can help them sleep, their family members, their bed partners, their gratitude is so rewarding that I think it becomes addicting. So with that, I will conclude, and I guess we'll take time for some questions.
All right. Thank you so much, Dr. Bennett. Great presentation. Just a ton of information and very useful. So thank you for that. Right now, we only have one question, and I'll read that to you so you can answer. Is there a CBCT airway volume minimum measurement and SDB correlations supported by literature?
So that's a great question, given the a lot of the marketing that's going on there, and I don't know the number. There are numbers that are somewhat, I don't want to say predictive, but correlate with an increased risk. But we have to consider in a CBCT scan, most units are going to be taken, the image is going to be taken in an upright individual. There's a number of individuals that have quote unquote small airways and they have perfectly normal sleep and sleep breathing, and vice versa. Also, the patient is awake. The pharyngeal tissues are going to behave much more differently asleep and awake. So what this information can give us in our imaging is more of a probability. Now, should we use this in routine screening? My answer, my opinion is no, and I base that on the amount of radiation with that type of volume. It's not benign by any means, but from a health perspective, if we can't justify that we're going to significantly change our diagnosis or our treatment plan with a diagnostic test, it's not considered ethical to do that test. So if in our normal workup we're looking for other things and we take a CBCT and we see a small airway, then or in large adenoids or in large tonsillar tissues, then yeah, that's appropriate, and that could lead you to more screening tests and ultimately a diagnosis. But taking that as part of a routine measure for screening your sleep disorder patients, to me, that's not acceptable. So I know I didn't answer the question as far as a number. There is some data out there, but just keep in mind that it's a propensity. It's factors that could be predispose a person, but it is not diagnostic, and it's not a validated measure to look at your patients.
Okay, thank you. That's the only question I have so far, but I'm going to talk for a moment. So any of you who would like to write in a question, please do so in the next moment or two. As I said at the beginning of the webinar, this is available for CE, 1 hour CE. We're going to have a small test, a very easy one, just to make sure you were here and paid attention. And that will be available and sent to you within about 24 hours. On occasion, it takes 2 days, but very soon. You'll take it, send it back into us, and we will send you the CE credits, or at least something you can send into the body that gives you the credits. The next thing is that this webinar was recorded, and it is available, or will be available again within about a day or so, on the whipmix.com website. You go to the home page, and right at the top there's a button that says webinars. You just click on that, find a category, and you'll see this webinar up there. The title of it was Practical Screening for Sleep Disordered Breathing in Clinical Practice. And by the way, there are other sleep disordered breathing webinars which are in that same category, several of them, which cover other aspects, including legal aspects. So for instance, if you can check whether you live in a state that allows a dentist to make a diagnosis or not. So, there are all kinds of interesting information there in webinar form. So feel free to visit our webinar site anytime you'd like. Of course, there's other subjects as well, many other subjects. So, Dr. Bender, there's one more that just came in. Has Dr. Bender ever heard of a recording oximeter named Biometrics O2 Vibe? Vibe, V-I-B-E.
No, that's one I have not heard of.
Okay.
I have used a number over the years. My personal preference is the Nonin or Nonin. I don't know how to say it. N-O-N-I-N. I've found them to be the most robust. In other words, I've had them for the longest, but that particular other brand I have not heard of.
Okay. Not that this is a commercial venture, but you can get the Nonin pulse oximeter from Whitmix, as a matter of fact, with the Profox software. So that's also a way to get a hold of that. No other questions so far. So with that, I will say thank you so much, Dr. Bender. Appreciate a great webinar, as always. And for those of you on the webinar, please feel free to come. We hold webinars every other Tuesday generally. Watch for an invitation to a future one coming your way very soon. And Dr. Bender, I'll be in touch with you within a day or two.
Okay, great.
So,
Thanks
thanks again.
Thank you.
Okay, bye-bye.